So good morning, everyone, and welcome to Grand Rounds. This is a special Grand Round. So once a year, we have our Brettell Lecture Series. The Brettell Lecture Series honors Bob Brettell, who was, perhaps the founding member of general internal medicine. He was, Dr. Brettell grew up in Wyoming. He was drafted into World War II. He served in the Normandy invasion. He was part of the troops that liberated Buchenwald, and his photographs of that actually hang in the Holocaust Museum in Washington. He married his college sweetheart when he came back, did training on the East Coast, came back to Denver to start his family, and was recruited by Dr. Minklejohn when he became department chair. And I think at the time was the only general internist in a very small department of medicine. He was responsible for helping to found the department of, or the division of general internal medicine. And then the Department of Family Medicine was actually an initiative of the Department of Medicine. So he was the founding chair for the Department of Family Medicine and then recruited his replacement. But of all the different hats he wore, the one he was proudest of was his role as an educator. So when he passed away several years ago, his family generously gave us the endowment that allows us once a year to bring a thought leader in topics related to education to the division. And so this year we didn't have to go very far to find that thought leader, which is just Dr. Lottie Dyrbye. Dr. Dyrbye is now actually a member of our faculty and a member of the General Internal Medicine Division. She was born in Denmark, and I think is probably the only person in the Department of Medicine who's fluent in Danish. She ended up spending formative years here in the Midwest. She went to St. Olaf for college, where she met her husband, and then went to college and her residency at the University of Wisconsin. She has been here 2.5 years. Is that 2 years? And she has a unique title. She is our, I don't know if you say CWO or CWBO. She is our Chief Wellbeing Officer. And I don't know if there's another Chief Wellbeing Officer in the country, but Dr. Dyrbye is uniquely qualified to take that on. Her research has really been groundbreaking in terms of thinking about how do we create environments and opportunities that maximize the well-being for learners and for physicians and other faculty. We normally sort of populate the couple of days of the Brettell lectureship with a schedule for our speaker. And since Dr. Dyrbye is just a couple hundred yards away most days, we found that our faculty either knew her and worked with her, or many other people had little knowledge of her work. So she's very generously offered to be available for people who would like to set up a time to meet if based on interest in the topics. So without further ado, I'd like to welcome Dr. Dyrbye.
All right, good morning. All right, so let's see. There we go. So I do have a disclosure. I'm a co-inventor of the Wellbeing Index and its derivatives, which is licensed by Mayo Clinic to a vendor. So these are my very well-written learning objectives for today. So I hope by the end of the session, you'll have, we'll have a common understanding of what burnout is, its prevalence in our learners, why it matters, and what we as individual faculty can do about it. Okay, maybe not. Oops, there we go. All right. So burnout, as many of you know, has been defined by the World Health Organization as a phenomenon that is really occupational, right? So it occurs because of a high level of unmitigated work stress. It is not a mental health diagnosis. And when we think about burnout, it really has these sort of three buckets. The most common one that we see is actually emotional exhaustion. This is depersonalization, which is feeling calloused or detached towards your patients. Emotional exhaustion is more about feeling that you're end of your rope, that you have nothing more to give. And a low sense of personal accomplishment, we actually don't see that much in healthcare workers, but that's this sense of that your work doesn't matter. So when we think about burnout and we study that, the prevalence of it in our learners, we quickly come to the conclusion over the last 20 years that, there's a big problem in medicine. In our learners, we see really a high prevalence of burnout as they are sort of acculturating to medicine, being exposed to our work environment. So about half of medical students have substantial symptoms of burnout. The rates in residents are probably higher, and they vary a lot by specialty. In fact, in our big multi-institutional studies where we have looked at residents really across the country, we see that when you compare to internal medicine residents, that the prevalence of burnout is higher in some specialties, for example, urology, neurology, emergency medicine, general surgery, while it's lower in other specialties, so lower in dermatology relative to internal medicine, even after you control for a whole host of other variables there that you can see on the screen. So this is data that I just pulled from the 2024 study of residents here in Colorado. And each number is a department. Everybody's blinded except for medicine, right? So I showed this to Vineet yesterday, and you can see the prevalence of burnout in our residents here in the Department of Medicine is certainly higher than some of the other departments, but not the highest. And overall pretty close, to sort of the overall mean. So our residents are not sheltered from work stress. Our residents are experiencing about the same level of burnout that I would expect based on our national studies. And when we look at burnout in our big population studies, we see that it is more common in residents than in similarly aged college graduates. We see the same thing on medical students, that it's more common in them than similarly aged college graduates. And of course, we all know it persists into practice with early career physicians also having more burnout symptoms relative to the US population. So that sort of begs the question, right? Is this Dr. Zimmer's fault? Is this Brian Dwinell's fault? Are we letting the wrong people into medicine? Are we somehow vulnerable to work stress? And that's why we see high degrees of burnout in physicians and other healthcare workers relative to others. People have written about the physician personality. If you're perhaps partnered with somebody who's not a physician, they're going to be like, this is totally you. But Gabor wrote about it years ago in JAM, and I think it still resonates, how we have this high sense of guilt, doubt, and responsibility. It's sort of part of our DNA. It's part of who we are. And in many ways that this is adaptive, right? It makes us attentive to detail. It makes us thorough. It makes us come to see me at 8 in the morning and all sorts of other times, right? Because we really understand the responsibility that we have, the trust that patients put in us. On the other hand, it can be a little maladaptive because we can have a hard time relaxing, setting boundaries, letting go, disconnecting, really taking time off, right? And does that sort of set us up? Are we sort of recruited into medicine for these good and not so good characteristics? And does that make us more vulnerable to job stress? So now, nearly a decade ago, we looked at matriculating medical students. So we all remember the journey, right? We were gunners throughout high school. We were gunners in college. We haven't gotten off that treadmill yet. But what did we look like when we started medical school? Well, in our big studies of medical students across the country, at least a decade ago, I have to admit this data is starting to get a little old, we saw that burnout and depressive symptoms were actually less in medical students relative to similarly aged college graduates. And on the flip side, when we use quality of life measures, we saw that the medical students at matriculation actually had higher quality of life across multiple different domains relative to other US college graduates. And this data does give us some suggestion, at least, that in the door, medical students start with preserved mental health. But then once they're sort of in our collective kind of wing, working and learning in our work environment, it flips. And we start to see high levels of burnout and depressive symptoms in our trainees. That's higher than age-matched population and persists into practice. So it sort of begs the question, right? Like, so what, right? Why Why does it matter? I feel like this skipped some, but okay, there we go. Well, the consequences are really broad, and they are both in the professional as well as in the personal domain. And I'm going to highlight just some of the literature because I think it's important to be able to articulate the so what so that we can get to the important part, which is really the now what, right? Kind of what do we do about it? What do we do about it as education leaders? What do we do about it as faculty at an academic medical center? We know from our research that there's a really strong ties between burnout and how we show up in the work environment, so our professional behaviors. This is comes from the study of residents at University of Washington conducted by Tate Shadefelt, really showing that residents who were burnt out were really had a much greater time sort of showing up the way that we all want them to show up, right? So they're discharging patients from the service kind of before that they were ready, not taking into account all the socioeconomic determinants of health, sort of et cetera, lots of different ways. When you look at professionalism and burnout, you see that it runs together in the way that you would expect. Similarly, in medical students, when they're burnt out, they're more likely to say they're cheating on exams. They're more likely to tell you on rounds that they've done a part of the physical exam that they haven't. They're more likely to tell you on rounds that a lab test is pending when they know it hasn't been ordered, right? They have a harder time sort of recognizing what's the right sort of approach to managing prescriptions, what's the right approach to managing conflicts of interest, what's the right approach to think about how to behave when you have an impaired colleague, right? So all these different dimensions, empathy, altruism, are all in the wrong direction when our trainees are suffering from burnout symptoms. And that really mirrors what we see in physicians in practice as well as in nurses. When we are burnt out, we are less likely to practice cost-conscious medicine. When we are burnt out, we have more unprofessional behaviors. When we are burnt out, we don't hold each other up to the standards that we expect in our profession. The other thing that we have seen in our big national studies of residents across the United States is a relationship between burnout and explicit bias toward Black patients. So this is a longitudinal study, started in the second year of residency of 3,300 residents, all specialties across the United States. And we followed them actually over many, many years. This is just looking at from the second year to the third year of residency. And overall, if you look at the entire cohort, bias toward Black patients actually goes down, sort of suggesting that our curriculum and our intentions are working, right? That we're getting some traction moving in the right direction. We also saw that the residents who had really the lowest degrees of burnout at both time points had the lowest amount of bias toward Black patients. And we saw that residents who recovered from burnout had the largest reduction in their bias toward Black patients. Unfortunately, there's a large group of residents whose burnout worsened from year 2 to year 3 of residency. And as their burnout worsened, so did their explicit bias toward Black patients. And that was even after a multivariate analysis, after we controlled for a lot of other factors, really suggesting that burnout may also be contributing to disparities in care. We've similarly seen relationships between burnout and performance on in-training exams for residents. This is a study led by Dr. West of over 16,000 internal medicine residents, looking at the relationship between their severity of emotional exhaustion and their performance on the internal medicine in-training exam. And what we actually found is that if you're a burnt out third-year resident, you're going to perform at the level of a second-year resident. Okay, so the differences were really pretty big and impactful, and aligns with the larger literature that when you have negative emotions, you actually don't learn as well, you don't recall as well, and you don't apply your knowledge as well. Others have conducted studies looking at the relationship between burnout and performance in high simulation scenarios. Again, seeing a relationship when the residents are burnt out, they don't perform as well in simulation scenarios. Residents also report a harder time sort of concentrating at work and being motivated. And that aligns also with the literature published by Dr. West showing relationship between burnout and residents perceiving at least that they've committed a major medical error. So this is symptoms of burnout at time point 1, and then 3 months later, sort of the odds of the resident reporting that they've committed a major medical error. And this is on multivariate analysis after controlling a variety of other factors. And what you see is a dose sort of response relationship, right? So for every 1 point worsening of emotional exhaustion, you see a 6% increase in the odds of a self-reported medical error. Now you can wonder, right, did the medical error really happen or not? That's obviously hard to know, but we all know when we think we've committed a major medical error, right, that it impacts us certainly, and there's a good chance it's impacted the family. In our studies of US surgeons, we know that those with burnout are twice as likely to be involved in malpractice litigation suit, sort of suggesting that there might be some sort of relationship. And I'll talk tomorrow more about the relationship between burnout and quality and safety. We think that there's a relationship between burnout and medical students and perhaps also residents leaving medicine before they finish their training. What we know from the AAMC data is about 3 out of 200 who drop out do so for non-academic reasons. And about half of those are thought to do so because of burnout or depressive symptoms. We've certainly seen in our study that there's a longitudinal relationship between burnout and seriously thinking about leaving medical school. We similarly see in our large studies of residents that, to no surprise, right, if they're burnt out, they're more likely to have career and specialty choice regret. Now, this is on a cross-sectional study, but when we look at it through a longitudinal lens, we see that burnout at the end of medical school actually predicts career and specialty choice regret the end of second year of residency, even after you control for a variety of other factors. Others have studied this as well, showing that if you're burnt out in your intern year, you're less likely to pursue subspecialty training. If you're burnt out in residency, you're more likely to consider leaving medicine altogether. But beyond these sort of professional ramifications, there are also personal ramifications when our trainees suffer from high degrees of burnout. We see, for example, this is a longitudinal study in medical students that we followed over the course of a year, that burnout predicted suicidal ideation, even independent of depressive symptoms, with a dose response relationship. We've also seen association between burnout and substance use disorders, particularly with respect to alcohol, both in our medical students as well as in our surgeons. Now, fortunately, at least if you look at data that's now, over a decade old, residents are not more likely to die by suicide than other similarly aged individuals in the population, with the exception of residents who are more non-traditional or over the age of 35. Despite that, the #1 reason why male residents do die is because of suicide. And for women residents, it's the second reason. The first reason is actually neoplasm. And you can also see that there's a big peak right in the intern year in the first quarter. And then again, right in the third academic quarter with respect to the number of suicides that the ACGME was able to detect over this, 14-year time period. So why is all this happening, right? Why do we see a high prevalence of burnout in our medical students, in our residents? Why is it higher than the general population? Where to determine that it's not because we're somehow letting the wrong people into school, right? And we know it has important professional and personal ramifications, but why is it happening? Well, when I was part of the National Academy of Medicine consensus study report that was released right before the pandemic, we reviewed, all the literature in this area, and there's a whole chapter if you want to look at it. It's free, it's online. There's also cliff notes if you don't want to read the whole chapter, but it really sort of summarizes what we know about student and trainee well-being and sort of this piece of the why. After reading over 5,000 articles and having listening sessions on both coasts, I decided that the drivers are complicated, right? They're multifactorial. They are housed within and outside of medical school, inside and outside of hospitals and clinics, right? There are so many different contributing factors, which is why burnout has really been called a wicked problem. But there are things that are in our control as faculty and as leaders in an academic medical center. And that's really what I wanted to spend the majority of the time talking with you about today. So I'm going to go through a little bit of data to help you give you an idea of what are some of the things that are within our control. So several years ago, I did a study looking at how year 1 and year 2 of medical school are structured. And we did this across 8 to 10 medical schools in the United States. And we basically, did things that you could like count, right? What could you reliably count off of a curricular map? Well, you could figure out things like how are medical students graded? How many hours do they have in lecture or small group or clinical experiences? At the time, I was the lead for clinical experiences at Mayo Clinic, so I really wanted that, to be protective. Like the more they're out there seeing patients, listening to heart murmurs, seeing rashes, figuring out how to take care of patients, they're not going to be so burnt out, right? They're going to sort of see the great part of medicine. And then we also counted up, how many exams they had, how many hours of exams they were in, and how much vacation they had. Of all these things, there's only one thing that predicted their burnout. Any ideas what it might be? Yeah, Rita knows it. Yeah, it's the grading structure. So the only thing that mattered is whether or not they were in a pass-fail curriculum. So that was the only thing that predicted burnout after we control for all these other factors. And it also actually related to whether or not they were having serious thoughts of dropping out of school. Now, fortunately, historical cohort studies suggest that when you have students in a pass-fail curriculum, they actually still learn in comparison to students who are in kind of a traditional 5-point grading curriculum. What we see is better well-being, and what we see really is no difference in measurable performance in the 3rd year. We see they perform similarly when there were numbers on step 1, when we had the step 2 clinical skills exam, and the clerkship grades don't appear to be any different. So we've also looked at other things beyond the first couple of years, looking at factors within the learning environment, looking at, are you in clinic? Are you in the hospital? Are you in the ICU? How many patients are you taking care of in the hospital? How many patients are you seeing in the outpatient clinic? Trying to get it for medical students' workload sort of issues in the clinical realm to try to tease out what are some of the other predictors of burnout in medical students. What we found in our multivariate analysis that the students' perception of support that they get from faculty was an independent predictor. Whether or not they had a cynical resident, okay, that's harder to control. How well rotations were organized, and whether or not they were seeing a variety of problems during their rotations. Those in the expected direction were associated independently with burnout. The things that didn't even come out at all were the number of patients that they were expected to round on, whether they were in the hospital or the clinic, whether they had call or how often they had call. So really sort of suggesting that the students expect and want to work hard, but need to do so in a well-supported, structured, organized environment. And despite our very best attempts, we continue to see that students are reporting a mistreatment. And as you'd expect, recurrent mistreatment, whether it's by faculty or by residents, is associated with medical student burnout, right? You'd sort of anticipate that. If you're getting mistreated, your stress is going to go up, your burnout is going to go up. We've similarly seen that when medical students believe their race is negatively impacting their medical school experience, they are more likely to be burnt out as well as depressed and have poor mental quality of life. And then we have the study, released in the New England Journal of Medicine several years ago, big national study of US surgical residents. 1/3 had experienced gender discrimination, 17% reported racial discrimination, 10% sexual harassment, and all of that was associated with higher odds of burnout, as well as suicidal ideation on their multivariate analysis. And heartbreaking is it was the attendings, right, that were the most frequent source of the verbal, physical, and even the sexual harassment. What's also notable in the study is that there was large variability in mistreatment by site. Okay, so sort of suggesting that culture is very much also playing a role. But these sorts of cross-sectional studies always lead to sort of questions about the chicken and the egg, right? The student is burnt out, so therefore, when we give them feedback, they're more likely to perceive that they're being mistreated. Or is it that our mistreatment of them is increasing their stress and making them have burnout, right? Like, what's the direction of the relationship? So this is a single institutional study looking at over the course of the third year, and it's looking at medical students' depressive symptoms on the Beck Depression Inventory. And what predicted their end of third year Beck Depression Inventory score was obviously their baseline depression, but also the role modeling that we have in the clinic and whether or not they perceived that they were being mistreated. We also seen our large multi-institutional studies looking at medical students from the beginning of medical school to the end of medical school, that negative role modeling and mistreatment were independently associated with depressive symptoms at graduation. So it was a negative racial climate. Really interesting group of studies. And this was regardless of the student's ethnicity or race, that these were 3 factors. And when we look in our studies of 14,000 medical students, we see that mistreatment reported in the second year, as well as the students' perception of the emotional climate within their learning environment, and their reported interactions with us, how helpful we are, how well we answer their questions, how constructive we are in the feedback that we provide them, that those are independently associated with their burnout, their career regret, as well as with their empathy. And looking into residency, we see that their reported negative interpersonal experiences at work in the second year of residency predicts burnout in the third year of residency, even after controlling for other factors. What you notice here is being a woman also remain an independent predictor of burnout in year 3. Now, there's a lot has been written about gender and burnout, right? Is it really an independent predictor? Are women somehow more vulnerable to burnout, or are we just more stressed out because of all things that are going on, or what's the scoop here? What we actually saw in this study is that the female residents were having so many more negative interpersonal experiences at work that's why they remained at higher risk. If you actually looked at the impact of a negative interpersonal experience at work, it was the same on male and female residents. It was just that the female residents were having so many more of them that being a woman remained an independent predictor of burnout. In many of our other studies, some of which I'll talk about tomorrow, we actually see that the gender difference goes away in practicing physicians once you control for mistreatment and harassment. So what about the GME learning environment? So we've looked at the GME learning environment with respect to the faculty behaviors that the residents are reporting, the faculty attitudes that the residents are perceiving, and how well we get that sweet spot with respect to provision of autonomy. Do we give them too much? Do we give them not enough? Do we get it right? And how that sort of relates to burnout. So these are cross-sectional studies, but in these studies, we did see, again, this issue of faculty support being an independent predictor of resident burnout. When we are genuinely interested in residents as human beings, when we know that they can speak Danish and like went to St. Olaf, right? These sorts of things, they are less likely to be burnt out. When they perceive we're generally interested, not only in them as people, but in their well-being, they're less likely to be burnt out. When we are accessible and trustworthy, when they see that, they report less burnout. Similarly, the residents who report that we are respectful, that we manage our time well in clinic and in the hospital, that we role model wellness and self-care, they are also less likely to be burnt out. The residents who report that they see us, admit the limitations of our knowledge, right? That we like, let's go check up to date. I'm not really sure what to do. What do you think we should do? Right? When we are willing to be vulnerable in the moment, when we encourage free and open discussions, when we provide constructive feedback, when they see those behaviors, the residents who report those behaviors, they are less likely to be burnt out. And when we get that sweet spot right, particularly with respect to provision of autonomy in the ICU, they are less likely to be burnt out. All of these issues, this faculty, resident faculty interactions, the professional behaviors that they see, their satisfaction with the autonomy we provide them, are also independent predictors of the residents' social support, their perceptions of social support. Interestingly, required off-campus rotations is not an independent predictor of their perceptions of social support. Now you can say, okay, why are we talking about social support, right? Well, it turns out social support is incredibly protective. If you actually take a group of soldiers who are exposed to a horribly traumatic event in the field, the single most predictive factor of whether or not they're going to develop post-traumatic stress disorder is actually their perceptions of social support. And we see this over and over again in the literature that social support is incredibly protective. And in our studies of residents, we also see that there's a strong relationship between their perceptions of social support and their risk of burnout, as well as actually their satisfaction with their training program and their sponsoring organization. I think it's this importance of belonging and inclusion and feeling, that you're supported in this really challenging work that we do. The other factor that's also independently associated with residents' perception of social support is how they perceive program leadership behaviors. So this is how they perceive APDs and PDs in their leadership capabilities. We've similarly found that how residents perceive the AP and PD with respect to their leadership behaviors is also independently associated with their burnout, their satisfaction with the residency and the organization. And even small improvements in leadership score would be associated with dramatic reduction in resident burnout. So what are these leadership behaviors, right? Are they hard? Do we have to go to Harvard, take some leadership courses to know how to do it? Turns out they're pretty simple, right? They're things that doesn't matter if you're an APD or a PD, they are behaviors that we all could do, as faculty with our trainees, as well as with people we're mentoring. Having career development conversation, inspiring, motivating, empowering, helping people develop their skills, being respectful, right? Giving people information, listening to their ideas. These are all pretty simple human behaviors that all of us could display in the work environment that would help with resident well-being. We've even seen in our longitudinal work in physicians that how we perceive our immediate physician supervisor is an independent predictor of our burnout and our satisfaction 2 years later. So leaders really have a big role in setting the culture. There are some other faculty behaviors that have been studied and shown to be associated with trainees' risk of burnout, including whether or not we're teaching explicitly about end-of-life topics, whether or not we're taking the time to actually directly observe them, and whether or not we're building reciprocal relationships. So that's where, it's easy, right? You're busy in clinic, you're busy on rounds, you have a learner, they're giving you information, you go take care of the patient, right? You go to the next one. They give you information, you go take care of the patient. So reciprocal relationship is where they give you information and then you give them stuff back, right? You teach them something, you give them some constructive feedback, you show them where the spleen is again, right? That's a reciprocal relationship. Other things that have been shown with respect to sort of what education leaders can do is to help build more flexibility where it's possible for the residents, setting reasonable research expectations. And then there's also some issues, obviously, with workload and with tuition or educational debt, harder things to move. We also have a role to play in helping learners actually appropriately get to help, right? So if we know about half of them are burnt out, a third of them are depressed, too many of them develop suicidal ideation, what is our role in helping our trainees sort of access care appropriately? What we've seen in our studies is a reluctance to go seek help for a serious emotional problem. So this is relative to the US population. Similarly, aged US population, medical students and residents, you see sort of this blue box. I would definitely go get help from a professional if I had a serious mental health issue. And, you know, it's like 20% of our residents said definitely, right? And that's having gone through the curriculum, understanding sort of, you know, why these symptoms develop and what kind of treatments are available. Now, in our multi-institutional studies in the UME environment, the medical students are telling us that they are seeing us reveal other students' emotional problems, so not being confidential. They're seeing us give students fewer opportunities if they're known to have an emotional or mental health issues. They're seeing us negatively judge students who are known to have mental health issues. And those sorts of behaviors are getting in the way of them wanting to access care. We see the same thing in the GME environment, that nearly half are concerned if they do take time away for an emotional mental health problem, that it's going to negatively impact their career. Many of them, as I mentioned, are reluctant to seek care. And 35% of them even have great difficulty just telling us, you know, that they have a medical appointment and they, you know, they need to sort of leave rounds early or whatever. Now, when we sort of graph this by specialty, so on the x-axis is reluctance to seek care, on the y-axis is concern over negative ramifications to our career. Internal medicine, we do pretty good. We're a pretty caring bunch in there with pediatrics and family medicine, but we have some challenges in the surgical specialties particularly, with creating an environment, a psychologically safe environment, where trainees feel that they can access care if they need it. And as you expect, the people who need the care the most are also the most reluctant to go. So, you know, if you're burnt out, you have a twofold higher odds of saying it's super difficult to tell a supervisor that, you know, I need to slip out to go to an appointment, right? They're much more likely to be concerned about negative ramifications to their career. And they are much more reluctant to seek care. But it's not all about you. Right? So the elephant in the room, obviously, is the practice environment, right? The learning environment, practice environment. How are we going to get to resident well-being when our workload is too high, when our healthcare system is incredibly inefficient, when there's understaffing, when our health information technology systems don't work well, you know, when we've got required online modules and MOC and in-basket and, you know, just like build it on. You know, how are we sort of going to get to improving the learning environment when they're working in our work environment? Particularly because at least 21 months into the pandemic, you know, although we had made some gains in the reduction of burnout across the United States, we saw, as expected, you know, a dramatic increase. I've just been looking at the most recent data here at the end of 2023-24. Looks like this is turning around, which is good news. But nonetheless, it's tough out there. And no surprise, right? The residency programs where we see the highest prevalence of burnout are the same specialties that we see the highest prevalence of burnout for practicing physicians. The residency programs that we see the lowest prevalence of burnout are the same programs or specialties we see the lowest prevalence of burnout in general in practicing physicians. And that has caused people to sort of ask the questions, is it unique factors within the work environment, right? Is it that sort of burnout is negatively impacting the learning environment, just the way that we are sort of behaving, right? When we're burnt out, we don't behave well, that negatively impacts the learner's experience. Or is it that somehow burnout is contagious, right? So these are all theories that have been sort of out there, right? That when we're burnt out, just the fact that we're burnt out, we're role modeling burnt out, being burnt out, so then learners are more likely to get burnt out. I think it's probably more the top two, but it's a really hard thing to tease out in our research. So sort of now what, right? So what we've heard is that there's a lot of burnout. It's more common in our trainees than in other US college graduates. It has important ramifications. The drivers are complex. They relate to things that are sort of structural, right? Like how courses are organized. They relate to our behaviors. They relate to factors within the practice environment. How do we sort of think about moving forward? How do we improve the learning environment? Well, we'll get nowhere without leadership commitment from all levels of this organization, any organization. We'll get nowhere if we don't consider trainee well-being a performance metric for the school. We'll get nowhere if we don't care enough to measure it and to try to make a difference. And we'll get nowhere if we don't focus on system level interventions. So that means thinking about how do we evaluate our trainees and our residents? Do we still use norm-based? Only so many can get whatever. Or do we think about criterion-based? Do we think about pass-fail? How do we think about optimizing and organizing and sequencing clinical experiences and rotation? And how do we think about building social support? Now, we know from not only the National Academy of Medicine report, also the US Surgeon General's report, the IHI's approach, the AMA's pathway, and the CDC NIOSH total worker health approach, that the path forward for all of us is one that's focused on leadership, infrastructure, measurement, and ultimately system level action. So all of these recommendations, whether you look at the National Academy, you look at the US Surgeon General, you look at the CDC, you look at the IHI, they all are based on this framework of human-centered design for improving the learning environment that basically starts with measuring, so filling out the survey, right? For sure, what's going on in the learning environment, what are the drivers, how are the residents and medical students doing, using the data to guide system level efforts. But then it's very much nothing about me without me, right? This sort of participatory leadership where we work with the trainees to figure out what are the things that we can do to improve your work and learning environment. Just like we want people to ask us, how do we improve things at Lowry, right? How do we sort of think about that from a boots on the ground lens, and then really being a learning organization. We're not gonna move the needle dramatically in 1 year or 2 years, right? We're gonna need to be at this really for the long run. But it can work. So this is an article published by Stuart Slavin in Academic Medicine a number of years ago. He doesn't know what worked, but he tried really hard for several years and tackled a variety of things within a medical school. He tackled course content, contact hours, scheduling, grading. He built learning communities. He tried to teach a little bit of resilience and mindfulness, which we can talk about. And he saw that over time, when he sort of looked at successive cohorts of medical students, he was able to slowly sort of bend the needle, make improvements in measures of their well-being. Similarly, kudos here to Colorado, recently published study looking at, should our residents go 4 weeks inpatient, 4 weeks outpatient, 4 weeks inpatient, 4 weeks outpatient, or should they go 4 weeks inpatient, 1 week outpatient, 4 week inpatient, right? So it was a pre-post survey design. It was using sort of historical data, but what they saw really is dramatic reductions in both emotional exhaustion and depersonalization by switching the residents to more of a 50-50 mix between inpatient and outpatient medicine. And if you think about it, it makes sense, right? Most of medicine is actually delivered in the outpatient world. So maybe we should train the residents to deliver some outpatient medicine. Just a thought. Great study. Kudos to the team, published in JAMA Network Open. Interestingly, several years ago in JAMA, there was a study published looking at us. Should we have 2 weeks at a time in the inpatient setting, or should we have 4 weeks at a time in the inpatient setting? And for our well-being, for our burnout, we should probably have 2 weeks. But it was not that good for teaching, right? So there's always, but super interesting paper. And obviously, given that what we talked about before about the perceptions that mistreatment, belittlement, and harassment still happening in the learning environment, we obviously need to continue our efforts addressing that. And that can really include having really new and accelerated efforts to define, what are the professional behaviors that we expect, holding each other accountable for it, and really through a sort of a growth mindset, helping faculty and others, when they do have shortfalls in the work and learning environment, to learn some communication skills and to improve. And with our clinical partners, it's really making sure that we have policies and procedures in place so that we feel safe speaking up to patients when they're being inappropriate. I think in our culture of, patient satisfaction, sometimes there's a hesitation to sort of toe the line and say, whoa, that sort of language of that statement is not in alignment with our values. And we need to make sure that our clinical affiliates have our backs when we do stand up for one another in the face of patient, families, and visitors' mistreatment. The other role is for us to think about, how we can be or become a really skilled educator. We've learned about, or we've heard about, how our behaviors in the workplace really impacts the experience of the learners. And just because we have an MD doesn't mean we're great at teaching, right? So many of the behaviors that we have studied really, you can think about them falling into 3 buckets, right? So sort of being congruent, right? Like finding resources in the moment, being trustworthy. Having positive regard for our learners is about being respectful, encouraging free and open discussion, being accessible. Being empathic, right? It's about being supportive, showing genuine interest in residents and in their well-being. Being congruent, having positive regard, and being empathic are basically the fundamental pieces of person-centered teaching, which is what Carl Rogers wrote about, right? And he demonstrated that person-centered teaching is associated with better learner outcomes. So he wasn't studying burnout, right? But he was studying things like achievement, better interpersonal functioning, and improved sense of self-concept. So I'd like for you to think about how to be like Carl, how to have person-centered teaching when you go out into the wards, when you're teaching residents in clinic. How can you be congruent, have that positive regard, and be empathic? And if you're too burned out to remember that, just think about TED, right? Teach like TED. So you probably all, or if you haven't, you should watch Ted Lasso. I was a latecomer to it, but really enjoyed it. Saw lots of person-centered teaching behaviors on display. We are building up some more tools and resources to help all of us be better educators. This includes sort of building out a variety of kind of micro tips, things you can learn walking to your car, right? Waiting for the meeting to start. Relaunching medical education grand rounds. The education symposium is being planned for early May 1 and 2, and building community for our clinician educators. So Amy Gardner is the new Associate Dean for Faculty Affairs, and the Academy is getting a big relaunch here early summer. The other piece that I think is important is to be or become a great mentor in terms of helping to promote a positive learning environment for our learners. Studies actually suggest that residents who have a mentor are less likely to be burnt out, or residents who are in programs that have structuring mentoring programs are less likely to be burnt out. And obviously, we know from Tyra's work that residents have a lot of imposter phenomenon. And during these mentor-mentee chats, we have lots of opportunities to promote a growth mindset. For example, by really being explicit, when I send you that Word document with your manuscript back and it's full of red changes, that doesn't mean you're a bad person. It means I care, right? It means that this is a way for you to get better. And I think sharing your resume failure, right? C.T. Lin, that was the first thing he did with me when I met him. I thought, okay, all right, it's kind of strange. But what he was doing was sort of trying to be congruent and authentic. Supporting psychological safety, right? Highlighting the strength that's needed to seek care. Sharing stories of recovery when that's appropriate. And promoting healthy self-care as a critical component to being a professional. These are all things that we can do during our mentee chats. And we can all display these leadership behaviors that I went over before, right? We don't have to be PDs or APDs to do these behaviors that are associated with lower resident burnout. And we can be or become a change agent. And I think this is really important, right? Because, we are working in a really complex practice environment. And we can be victims to it, and everybody else's fault that nothing works, that work stress is too high, that there's workforce shortages, that my in-basket is out of control. Or, we can try to do something about it to improve our work environment, to engage in that process. And I'm going to talk more about that tomorrow at 8. It is not the same talk. I'm going to talk about, what we need to do really in the practice environment, how we can take steps to improve well-being of the faculty, because these two pieces are intertwined, right? We can't improve the learning environment. We don't improve the work environment. We can't have residents with less burnout if we don't have faculty with less burnout. But I hope that this talk at least gave you some tips and some things to think about as you sort of work with learners here on our AMC. So thank you for your attention. Happy to take any questions for those of you who have a few minutes to stick around.
So, get on the microphone so people can hear. So the first question from Rachel Swigris, could you comment on your thoughts about the data of a pass-fail curriculum and passing rates of STEP exams?
Yeah, so I was involved in the NBME's sort of decisions around, should we go to pass-fail for step 1 or not? There's a lot of data around medical students' mental health as they approach step 1. And it is what you'd expect, right? It goes down the toilet. They isolate, they study. So that was one of the factors that sort of led to that pass-fail decision. Did it just sort of postpone the stress, right? Did it just postpone it? What were the unintended negative consequences? I think those are the things that, everybody is still sort of trying to sort out. Pass-fail curriculum in the first couple of years of medical school, I do think, is associated with a reduction in burnout and doesn't impact performance in year 3. Residency programs actually don't look at your grades from the first couple of years of medical school. So it seemed like an easy thing to do. But this piece around pass-fail for step 1 and maybe also for step 2, I think it's sort of hard to know if that's the right thing or not.
Paul?
So any data about, I couldn't hear all of your questions. Well, it certainly does in the lens of mistreatment, right? So about 1 in 5 doctors report that they've been mistreated by patients, families, and visitors, right? And that is more common in racial and ethnic minority physicians. It's more common in women physicians. And that is very much associated with burnout. It's super interesting with the National Academy of Medicine, we have sort of patient advocates on there. And whenever we sort of want to talk about patient, family and visitor mistreatment, they're like, oh no, we can't talk about that. And I'm like, it is part of it. Societal expectations are also part of it, right? Sort of if patients don't get a reply to your in-basket message in like a day, right, they send you another one. Part of that, I think, is because we haven't trained patients really in what the in-basket is for and how to use it. But part of it is also this 24/7 culture, right? Oh, I just took my last pill. I should have a refill now. So there definitely are these broader societal factors.
Katie.
Yeah. Yeah. Yeah, so I figured you guys had already heard lots about,
Would you just repeat the question too?
Yeah. So it was about coaching, right? And we know that, for example, the Better Together coaching programs and the residents really does have measurable impact. We've seen it in the single institutional study. We've seen it in the large multi-institutional study led by Tyra and Adrian, and its impact. We've similarly seen that professional executive coaching for physicians in randomized control studies also makes a difference. Now, in those studies, it's individual one-on-one. It's 3.5 hours over the course of 6 months, and the effect does wane. So when we look at post-intervention effect, we see that the effect does wane. But nonetheless, there is something to be said for coaching. Yesterday, I was on the required training for supervisors. Did anybody else have to do that? It was Department of Medicine, required training, right? I have a PRA. I think that's how I got looped into having this required training. And it was all about having coaching conversations, right? I think the more all of us sort of learn these coaching conversations or communication skills, probably the better off, the whole environment will be. So yeah, really important piece. And I think a piece of the puzzle.
Jarrett.
Thank you. I think the average medical student debt is like $230,000.
Yeah.
And I'm curious in any of your research how that played out. Burnout. Your graph about where you're showing like high, especially high amounts of burnout versus low. Those are all the high paying specialties. I guess specialties. If you're thinking kind of those going into it, that debt is hard. Especially that burnout. So I'm not if you have any comments.
Yeah. Yeah. So in our big multitudinal studies of medical students, it's not an independent predictor, but they were conducted back in the day. My husband hates when I say that. And I think this is still true now. Actually, when you're in school, you're not paying, so it's a little bit of a funny money concept, right? But then we do see in residency, we start to see it's a predictor, right? Particularly now, like back when I was a resident back in the day, we didn't pay our loans at all until we were done with residency, and that has changed. So it is a stressor. We see that medical students who work for income while they're in school are less likely to recover from burnout. So it's really something that we encourage students not to do, particularly if they're feeling high levels of sort of school stress already. But it's a piece of it. And education debt reduction, is also one of the things that we advocate for, but it's a tricky piece. It's tricky to try to figure out how to drive down tuition costs for students.
So there's a question in the chat. So we have a number of faculty who are researchers who are not clinicians. And so the question is, what's known about burnout among postdoc researchers, junior faculty researchers who aren't clinicians? Yeah,
so very little. There's been a few, mostly single institutional studies, right? Even, when we looked at it at Mayo Clinic, we saw high prevalence of burnout in our sort of PhD research faculty, as you would expect, right? The contributing factors are different. The work inefficiency issues are different, right? Obviously, it makes sense for those of us who sort of do a little bit of both. Here, we actually have, for a single institution, one of the largest cohorts of sort of scientists associated with an academic medical center. And in, looking at the 2024 data, there's a lot of burnout in our scientist colleagues. And we're going to be working on really addressing that through a similar process, right? Thinking about it at the level of the system. This isn't happening because scientists or doctors have a resiliency deficiency, right? It's happening because we need to make some system level improvements.
And one more question in the chat. Are physicians still required to declare that they've sought help for mental health issues or substance use disorders when they apply for licenses, DEA, et cetera, not to mention when applying for academic jobs?
Yeah, so this is something I'm going to address tomorrow. This has been a really important passion project that I started on, 2014 or 2017, maybe, I can't remember, looking at medical license application questionnaires and whether or not they were asking overly intrusive questions about mental health, right? Like, have you ever had depression? For example, did you have, postpartum depression? And then, if you indicate, yes, you have to explain it. And these sorts of records are often public record, right? So much for like HIPAA and all those things, right? Doesn't apply, to physicians in practice. over the course of the last decade, many states, because of advocacy work at multiple levels, have actually been changing their medical license application questionnaires to no longer asking about mental or physical health, or asking, are you currently impaired from any health condition, or simply not asking at all. And that's in alignment with recommendations from the American Psychiatric Association, as well as the Federation of State Medical Boards. The next frontier, though, is hospital credentialing questions and medical malpractice insurance questions. So it's an ongoing battle. I would say here in Colorado, you know, we're not asked overly intrusive questions on our medical license application questions, you know, nor when we are completing our credentialing questions for UC Health. I don't know about our other clinical affiliates, but it's something that we need to continue to do advocacy work on. And there's lots of momentum with the Federation of State Medical Boards, with the AMA, and with other national societies to continue to work on this. So thank you all for your attention.
Thank you, Lottie. And I think you can tell from the questions how salient this topic is and important. So thank you for being here.
Thanks for the invitation. Great.